Assalamu alaikum, dear all. Our today's session is about a very important aspect of ECG, and it relates to actually the most important cases, and I would say those cases which, if you can recognize at the right time and you pick them at the right time, you can save a lot of lives. So basically, the session would be mainly revolving around the ECG segment related to ischemic heart disease. And when you talk about that ECG segment, you need to focus on three things mainly, which we'll be studying in today's session. And these three things are: one is ST segment, second is T wave, and third is Q wave. So these will be sort of abnormalities we'll be discussing in the time ahead, likely in the next 40 to 45 minutes. So we start with ST segment. As I draw the ECG here, so that you would be knowing about all these components well, as we are supposed to discuss today: one, ST segment; two, T wave; three, Q wave. So you should be knowing that in ECG waveform, how do they look like? Talking about the Q wave, this represent septal depolarization. So this wave is P wave, this is Q. This is known as septal depolarization wave. Then what is the T wave? T wave is the ventricular repolarization wave. And then this is the ST segment. From the end of S wave to the start of this T wave, this part is known as ST segment. So we'll be studying these three things mainly. We start with ST segment. If we have to discuss anything related to these three things, either the ST segment will be normal or it will be abnormal. And if it will be abnormal, it will be either elevated or it will be depressed. So there would be two abnormalities in ST segment. ST segment. So either it will be elevated or it will be depressed. And both these things are having different differentials. Elevation has four important differential which you must be knowing. Depressive ST segment depression is also having 2 to 3 important differential which you guys should know. 2 to 3 differentials are enough as far as that depression is concerned. So what are these differentials? And when we will consider the elevation important. Now you understand the basic principle that there is an ECG paper and there are lines drawn on that ECG paper. So I am drawing those lines just like you see in the ECG paper. The horizontal lines represent the movement of the stylus. So it is basically the horizontal line indicate the speed and the vertical line, they indicate the voltage. So this is how the paper look like. This is how the paper look like. When we'll declare that ST segment is elevated, there are two important things. One, the elevation should be there in two adjacent leads. And when I speak the word lead, as we discussed in the previous session, different walls of the heart are represented by different leads, like inferior wall, 2, 3 AVF. So I just give you an example of inferior wall. We have got 2, 3 AVF, which represent the inferior wall. Anteroseptal wall is represented by V1, V2, V3. Anteroseptal V1, V2, V3, V4. Anteroseptal collectively. Lateral wall 1, AVL, V5, V6. So I'm just giving you an example. So when we consider that ST segment is elevated, what are the two important principles? One is the elevation should be there in two adjacent. What do you understand by the term adjacent? Two is adjacent, same wall. So basically that representation is of the same wall. And in particularly, like if we talk about the lateral wall, this is one AVL, then V5, V6. And as I told you about the heart, this is the lateral wall. So this high lateral portion is represented by 1 and AVL, and low lateral represented by V5, V6. So giving this example, this is adjacent to this lead, 1 and AVL. So there would be elevation in 1 and AVL in ST segment like that. If this elevation is in 2 leads, then I'll take it significant. If it's in 1 lead, it might not be significant most of the time. So that is necessarily to be seen to adjacent lead. V6 is adjacent to V5, 1 is adjacent to AVL, 2 is adjacent to 3, 3 is adjacent to AVF, and that's how thing goes. Same way, anteroseptal wall myocardial infarction, V1 is adjacent to V2, V3 adjacent to V4. So what are the two principles? One, there should be elevation in 2 adjacent leads. And second, when you talk about limb leads, now this would be the situation. That's an ECG, right? This is a normal waveform. And then you see elevation. This is elevation. So the second thing is, how much elevation should be there? In the setting of limb leads, more than 1 mm elevation. One small box on ECG present 1 mm, right? So if the elevation is more than 1 mm in limb leads, and you understand by limb leads, what do you mean by limb leads? Lead number 1, lead number 2, lead number 3, and then AVF, AVR, and AVL. So in limb leads, the criteria will be, limb leads criteria is greater than equal to 1 mm elevation. And talking about the chest leads, the criteria is greater than equal to 2 mm elevation. So when you talk about the chest leads, V1, V2, V3, V4, here that criteria is applied. For lateral wall lead, the criteria remains the same, like that of the limb leads. But for chest leads, V1, V2, V3, V4, the criteria is greater than equal to 2 mm elevation. So the two things, one, adjacent lead elevation, and then this is the criteria. Based on this criteria, now what are the differential of ST segment elevation? This was a normal wave, and then all of a sudden something happened, that wave got elevated. We label it as ST segment elevation. The most important diagnosis is myocardial infarction, which we know as STEMI, ST elevation MI. There is another thing, STEMI, where ST elevation is not there, but there is an infarction. When you speak the word STEMI, it means transmural infarction. Through and through the wall of the heart has been affected because of the vascular supply. And when you talk about this STEMI, then this is subendocardial infarction. That is not through and through. And when you talk about the unstable angina, then what do you mean? Neither there is transmural infarction nor there is subendocardial infarction, but there is just decreased blood supply to the walls of the heart. So this unstable angina, non-elevation MI, and ST elevation MI, you must need to understand before discussing the further differential. In next 1 minute, I just want to highlight the importance of acute coronary syndromes here, because this is what we are going to discuss ahead. Acute coronary syndrome, it's basically a continuum. Like initially, a person is having stable angina. What do you understand by stable angina? A person is walking around and then he or she comes to you and claims that he feels intense pain over the chest. The chest pain worsens on exertion, and the same way the chest pain worsens on the intake of meals. So if somebody is having that kind of chest pain which worsens on exertion, which worsens on the intake of meal, and that is involving the chest wall, maximally up to the epigastric region, can go to the right arm, can go to the left arm, can go to the lower jaw but never upper jaw, can go to the epigastric region but never umbilical region, can go up to the scapular blades but never lower than that. So these are the landmarks. Beyond these landmarks, the ischemic heart disease pain doesn't radiate. So if somebody is having that kind of discomfort and he feels that on exertion, on post meals, he feel intense pain, discomfort, heaviness, this is called classical anginal pain, classical typical chest pain. Now that person claims that as he take rest, he feels relief in his symptoms. Or he says that as he takes sublingual nitroglycerin tablet, he feels significant relief in his symptoms. But a day comes when he tells us another story that even after 30 minutes of rest, I'm not having relief in my symptom. Now that has changed to acute coronary syndrome. The same person claimed that I have taken 3 tablets of sublingual nitroglycerin after intervals of 5 minutes, which is the standard protocol, and despite that, still I am having that discomfort and pain. What it suggests? The patient has jumped to acute coronary syndrome. So basically, this is kind of a continuous process, a continuum where the stable angina has now converted to ACS. And when you talk about ACS, how to proceed ahead, it's very simple. A person comes to you, you get his ECG done, that is the first thing. After symptoms, which suggests you that probably this person is suffering from MI, and usually in the presence of lot of those risk factors, you just ask him, the first thing you always get is ECG. And in ECG, you find that elevation which we are discussing, we'll label it as ST elevation MI. But then there can be 2 situations. You're not finding elevation there. What you will do next? You will get his cardiac enzymes done, highly sensitive TROP-I done, and if it is elevated, we'll label the patient as a patient of, obviously excluding the other reasons for TROP-I, we'll label him as non-ST elevation MI. And the last thing and the rest is unstable angina. So if enzymes are not elevated, symptoms are quite typical, then you label the patient as a case of unstable angina. So this is the story of ACS. You need to stop things then and there. Whenever patient jumps to this sort of situation, immediate interventions are needed. Primary PCI is needed if he's having ST elevation MI. And it's very important to recognize these sort of changes and symptoms in the patients. First is ST elevation MI. The second differential is pericarditis. The third one is aneurysm. So heart valve aneurysm represent the same way. That can be ventricular aneurysm, that can be aortic. So any heart valve which has been affected, there can be aneurysmal formation there, and this is another differential for ST segment elevation. The fourth is Prince-Metal angina. Prince-Metal angina. So it's enough to memorize these 4 differential of ST elevation MI. How you would come to know? A patient comes to you in casualty, you get his ECG done, you find elevated ST segment, then how will you come to know which among those is responsible for his ST elevation? So symptoms typically suggestive of myocardial infarction are there. Your top possibility going to be this ST elevation MI, and obviously you would be getting his enzymes done, which would further strengthen your diagnosis. Talking about pericarditis and MI, the ST elevation is little bit different. Just look at the picture. Look at the picture here. One ECG which I am drawing at the moment, this you are seeing here, there can be another shape. So there can be elevation like that. So you can see here that this is convex upward. So when the things are convex upward, suggestive of this ST. When the things are concave upward, this ST is elevated, but this is concave upward, then this can be pericarditis. But the more catching point is, Myocardial infarction gonna be wall specific. I mean, if somebody is suffering from inferior wall myocardial infarction, he or she would be having 2-3 AVF ST segment elevation. If somebody is having lateral wall myocardial infarction, he would be having 1 AVL V5 V6 elevation. Somebody is having anteroseptal infarction, V1 V2 V3 V4 elevation, anteroseptal MI. Posterior wall MI, a person would be having elevation in the V7 V8 V9 lead, or there would be depression actually in V1 V2, which will be suggesting the elevation, as we would be seeing the mirror image. So I mean, that would be wall specific. And pericarditis, is it wall specific? You would be finding elevation in all the leads, in all the chest leads, limb leads, you would be finding that elevation. So one student once asked me, as I was telling him that that's the way how to differentiate. He said that if person is very unlucky and he suffers from infro, latero, antro, septo, postro, right myocardial infarction, sir, how would we be knowing? I told him, well, that person, if that unlucky, probably doesn't deserve to live. However, you won't be finding usually that kind of situation in practical life, right? Then the third is aneurysm. Now a person again comes to you in casualty and he is all asymptomatic. You find his ECG and you just recall what you have learned, and you see that there is an acceleration MI. You just ask him, sit there, do not move. You look very serious. The person claims, I'm not serious at all. I just played a hockey match and I have come here for some other reason. This is purely incidental. But being doctor, and as you must have already seen this elevation, you might be having that kind of impression that he is very serious. I mean, a person would not be symptomatic. In the setting of aneurysm, if person is having, say, anteroseptal myocardial infarction, somebody had anteroseptal myocardial infarction 1 year back. What this myocardial infarction does, through and through infarction, through and through damage, that result in thinning of the wall. Aneurysm is abnormal dilatation and thinning that can be there in vessels, that can be there in the walls of the heart. So if wall of the heart is damaged or vessels are damaged, like the vessels are damaged, tunica media gets damaged, intima and adventitia, they are very thin, and as the walls are very thin, they bulge because of pressure, and that bulge is known as aneurysm. So if we are seeing heart here, patient was having myocardial infarction involving the anteroseptal wall, a time may come when he may develop something like that. This is a abnormal dilatation after the thinning out of the wall. So in such kind of a person, the symptoms will not be there. The ECG, that ECG which he had 1 year back of ST elevation, that will persist because of his aneurysmal formation, right? So no symptom, asymptomatic patient with such elevation, and then you would do something next as well, because you may come across a patient who is not symptomatic. He is having myocardial infarction, but he is not symptomatic. That is always a possibility. Like in the setting of diabetes, a lot of people are having silent myocardial infarction. So you would also get his enzymes done, and you would also get his echo done, and then you would be coming to know that this is because of aneurysm, and that elevation will persist with the life of the patient. Then fourth one is Prince metal angina. Anybody among you in love with Coke? Coke lovers? Anybody? No one? Okay, fine. Bicard of Coke, right? So I was talking about cocaine here. So in Europe and elsewhere, lucky enough, so Europe and elsewhere, they call, when they speak the word Coke, what do they mean? Cocaine, right? So cocaine is one of the commonest reason behind this Prince metal angina. This is also known as vasospastic angina. So what happened? That in certain situations, like with the usage of that cocaine, the vessel go in temporary vasospasm. What it will lead to? As there is a compromised blood supply, so patient wall of the heart has compromised blood supply. So what will happen? Exactly the same kind of elevation. How you would come to know that this is not Prince metal, this is not myocardial infarction, this is Prince metal angina. The things keeps and goes, keeps and goes. I remember a case when I saw in casualty around 17, 18 years back, that we were just planning. We actually were not very well aware about that picture, and the senior was not there. However, we did call and then started talking to him when we saw something unusual. We were preparing the streptokinase injection, SK injection. Patient never gave us history of cocaine or any other major potential risk behind this vasospastic angina. And as we were preparing, the thing settled down. Then we said that lucky enough, you are having spontaneous resolution of symptoms. We just counseled him that way. And immediately onwards, as we were approaching towards the other patient, his monitor showed again elevation. So we again replanned that let's infuse. As we were about to infuse, it again settled down. And then we had to call and talk to someone who told us that this might be the problem. And it turned out to be vasospastic angina. So these cases are not that frequent, but you should have a good understanding. And many a time, vasospastic angina patients do get this streptokinase, thrombolytic therapies. We are having this streptokinase elsewhere in the world, developed world. They are having better injections, and however, in near future, we would be having the same thing here with us as well. But right now, primary PCI is being done, so injections are almost kind of obsolete. So they are given in certain situations. Total story of this ST segment elevation, it's for differentials, right? And talking about the depression, ST segment elevation, here we are talking about angina. So in the setting of angina, ischemic heart disease, ST gets depressed. Any other differential? In the setting of electrolyte imbalance, certain electrolyte imbalance in the setting of hypokalemia, like hyper, T wave elevated, T wave get depressed, ST gets depressed to some extent, hypomagnesemia, hypokalemia, digoxin toxicity can sometimes lead to the same kind of picture. So you may see depression in these certain situations. So these are the total differentials. Now the next important thing, how a person goes through different stages as far as his ST segment is concerned, as he or she suffers from myocardial infarction. Just focus on these 5 stages. A person had typical ischemic heart disease symptoms, typical myocardial infarction symptoms. These typical myocardial infarction symptoms include 1, this typical chest pain, 2nd, sweating, drenching sweating, 3rd, vomiting. So these are considered the classical symptoms of myocardial infarction. So a person had, say, I am just drawing an inferior wall here, a lead number 2 here. So that's the normal lead number 2. What happened to that person? Stage number 1, hyper acute T waves. The time is less than 30 minutes. So in less than 30 minutes, what will happen? This would be the picture of the ECG. You need to understand it because ST has not been elevated, but this thing is there. If somebody is not having good understanding of hyperacute T waves, he might be missing that myocardial infarction earliest stage. And if you can catch that myocardial infarction at the earliest stage, that is the bestest thing. So in less than 30 minutes, this is known as hyperacute T waves. ST doesn't elevate. Then greater than 30 minutes, the second stage is then elevation of ST. So this is the second stage. Greater than 30 minutes, now ST will elevate like that. Here elevation, this T wave is like that, and this is the picture. Greater than 30 minutes, usually less than 2 to 4 hours, this ST elevation is seen. Stage number 3. What happens next? What happens next is there is diminution of R wave. Diminution of R wave. Diminution means reduction in size of R wave. Like this is the picture. This is going to be the picture. So what's going to happen? If this is diminishing, actually due to the lack of blood supply to certain wall of the heart, a window is being created there. And then if we do not successfully revascularize the patient, what will happen? The whole window will be created, and first there will be diminution, and then ultimately there would be Q wave formation. The wave which was like that will become like that. The current will be exactly opposite. The wave will be exactly opposite. The third stage is diminution of R wave, usually more than 2 to 4 hours. Then the fourth is biphasic T wave, and these things can, go upside down. The biphasic T wave may be present, and then lately this diminution. So these two things are almost, they come together. Biphasic T wave, again 2 to 4 hours time is there, and then this would be the picture. What do we understand by the term biphasic? A T wave is there, and a T wave is below the baseline, above the baseline, below the baseline. Then next stage is, after biphasic T wave, a T wave may get inverted altogether. It may not get inverted, but it may get inverted. So then T wave inversion, usually greater than 4 hours, you may find T wave inversion. Now the picture would be a small Q wave and then ST segment elevation with that kind of T wave. So that is typical T wave inversion. And then stage number 6, if successful vascularization has not been done, this is going to be the picture. There may be normal T wave, there may be inverted T wave, so that can be any shape. Now just see the picture, what has happened. See this picture and see this picture. What's the difference between these two? Here, this is P wave, Q wave, R wave, S wave, T wave. We call it QRS pattern. What has happened here? This is Q wave and this is S wave. We call it QS pattern. So a person QS pattern who had myocardial infarction in past, or where more than 6 to 12 hours have passed, a person would be developing a Q wave. A window has been formed, the wall of heart has been damaged, the current will be exactly opposite. So on ECG waveform, you will be seeing a Q wave. So please remember these 6 different steps. Here the last one is Q wave formation. So remember these 6 stages. A person necessarily may not be going through all these 6, but in many cases, that is the sequence which you see in the setting of myocardial infarction. Remember this thing. This is another very important thing. So that was all about ST segment elevation. 4 differentials, points to remember. 4 differentials, remember 4 differentials. Remember 2 to 3 differentials of the depression. Remember the 6 stages through which a person goes when he or she suffers from myocardial infarction. And then 2 important points, that whenever you are seeing the ST segment, see into adjacent lead at least. It is desired. And then in the setting of limb leads, the criteria is greater than equal to 1 mm elevation. And in the setting of chest lead V1, V2, V3, 4, the criteria is more than 2 mm elevation in the adjacent lead. Now we are moving towards another thing, T wave, right? So next thing is now T wave. T wave is repolarization wave, ventricular repolarization wave. Again, what can be the abnormalities? Either it will be hyperacute, or it will be inverted, or it can be flattened. So these are the abnormalities of the T wave. Hyperacute T waves are of 2 types. One I have already showed you, and the second one I'll be showing you now. So one is like that, but one is of this shape. There is a tent formation, tall and tented. If I'll be speaking the word tall and tented, it would be indicating hyperkalemia. And if it's not tented, we would be taking it as hyperacute T waves in the setting of myocardial infarction, right? So remember these two things: tall and tented, and then simply tall and broad. Remember the words tall and tented, tall and broad. So that's about the hyperacute T waves. Then inverted T waves differential. 1, 2, 3, 4, 5. At least 5 important differentials in your mind. First one is ischemic heart disease. The same way the ST segment gets depressed, T wave gets inverted. So ischemic heart disease is the most important differential. Second differential is hypokalemia, electrolyte imbalances. Hypokalemia, same way hypomagnesemia. So these different sort of electrolyte imbalances can be there. Then you may see that inverted T wave in the setting of hemorrhages, hemorrhagic CVA, subarachnoid hemorrhage, SAH, you can see in these situations. Then you can see the inverted T wave as strain pattern. You can see inverted T wave as strain pattern. Understand what strain pattern is. Strain pattern is if there is increased pressure in the wall of the heart. Say a person is having pressure overload state in the left chambers of the heart. What are the 3 pressure overload states in the left ventricle? One is known as aortic stenosis, one is known as hypertensive heart disease, the third is known as HOOCM, hypertrophic obstructive cardiomyopathy. It's simple. Either there is some pressure built inside which is just continually pushing the walls of the vessel, walls of the heart, and ultimately resulting in left ventricular hypertrophy, or there is narrowing of the outlet aortic valve. So what will happen? Again, there will be more pressure. So in these pressure states, what will happen? The maximum burden is taken up by the lateral wall of the heart. The maximum burden as is seen in the lateral wall of the heart, and lateral wall is represented by 1 AVL V5 V6. So what would be the picture you would be seeing in the lateral wall? That would be the picture. So you would be seeing this kind of ECG in the lateral wall. Look at this T wave. I am drawing 2 waves now, 2 T waves now. One T wave is like that. Another T wave is which one is symmetrical? The first one. If I draw a line right in the center, the 2 halves are equal. If I draw here, that's entirely a different picture, right? This is what we call asymmetrical T wave. So whenever you see such kind of asymmetrical T wave in lead 1, AVL, V5, V6, you would be saying a patient is having strain pattern. Whenever strain pattern is there and somebody asks you what can be the underlying reason, you should immediately come up with an answer. There are chances that this person is having some pressure overload state, right? So remember this strain pattern, asymmetric T waves. And normally the T waves are like symmetric T waves. If somebody is having right ventricular strain, what are the leads which represent the right ventricle? RV4, RV5, as I told you earlier, or right side R1, R2, R3. So the lead number V1, V2, that represents the right ventricle, or on right, if we get right side DCG, then the lead number RV4, RV5, RV3, these would be representing the right wall. So those leads will be showing this kind of asymmetric T wave inversion. So that was another differential. Then digoxin toxicity. There are other drug toxicities as well. One of the reason might be digoxin toxicity in the setting of T wave inversion. There are many other reasons, but I just want to highlight few of the important ones, right? So that's all about T wave inversion, T wave elevation, and in the states where it gets flattened, that is usually seen in a dynamic process of hypokalemia. Like a person is hyperkalemic, this is elevated, then he is going towards that hypokalemia stage will come when that will be flattened, and then as the potassium will drop more, there would be depression, and there are U wave formation and few other things. So that's about the T wave. And usually when you would be seeing that T wave, again, usually that T wave inversion, when we'll consider it important, or elevation, when we'll take it, rather, I shouldn't say elevation, tall and tented or hyperacute, again, preferably two leads. If you would be seeing this changing two leads, this would be much more significant. Usually it is not seen in the isolated lead. Q wave is very easy. Q wave, when it is normal and when it is abnormal. And before jumping on to the next thing, very important point related to the normal T wave, inverted T wave. So a T wave can be normally inverted as well. Recall that I told you that if the direction of flow of current is towards the cardiac axis, say in a person the axis is directed like that, so the lead which is exactly opposite, which is AVR, is normally showing T wave inversion. So that's normal T wave because it is exactly opposite to the cardiac axis. In a certain person, a person is having right ventricular hypertrophy, the cardiac axis will be directed like that because axis is pulled in that direction where a wall is more hypertrophied. So now axis is like that, then which wave will show the T wave inversion or a Q wave? The lead which is at this angle, this is 1 and AVL. So 1 and AVL would be showing this kind of picture. So do not get confused. Always see the axis first. Axis change the shape of all the 12 leads. But what we discussed in last session, I told you how these 12 lead waveform is formed. So the point was that if something is towards the cardiac axis direction, everything will be above the baseline. Something is exactly opposite to that, it is below the baseline. If the axis changes, then this direction, the lead in this direction will be showing positive deflection, like this is lead number 3, and the lead in this direction, which is AVL, that would be showing a downward deflection, right? So remember this point as well. So talking about the normal T waves, the normal T waves are seen in 3 situations, in 2 different situations. One, as I have already told you, and same way, lead number V1, V2 can show the normal T waves. In usually males, it is up to V1 or occasionally V2. But in females, V1, V2 and V3 all can show normal T waves. So remember this thing as well, so that you won't be confusing. In females, it is as per ECG that females are more deceptive than males. So it's as per ECG. It's not what I'm telling you. V1, V2, V3 can be deceptive in females, but not in males, right? It is probably because of the breast tissue shadow, breast tissue. The things are not very well formed, और उनकी थोड़ी सी positioning change होती है. Now move on to the Q waves. Q waves again can be normal. Again, the same lead. I'm in the lead which is exactly opposite to the normal cardiac axis lead. So in AVR, you would be seeing a normal Q wave. In AVR. Same way, lead V1, V2 can have normal Q waves. When Q wave is considered significant, now the points you need to understand. When a Q wave is considered significant, this is again I'm drawing ECG with a Q wave. Say this is lead number 3 in a certain person. This deflection is known as Q waves. There are two criteria. One is if it is greater than 1/3 of R wave. Greater than 1/3 of R wave. Then it is considered significant. What do I mean by that? Look at this picture. Do you think this is greater than 1/3 of R wave? Now this is greater than 1/3 of R wave. R wave is, what is R wave? Any upward deflection. Remember this line, very important line I am going to highlight here. Any upward deflection in QRS complex is known as R wave. Any downward deflection before the R wave is known as always Q wave. Any downward deflection after the R wave is known as S wave. So you always start like that. Any upward deflection in QRS complex is known as R wave. Any downward deflection before the R wave is known as Q wave. After the R wave is known as S wave, right? So if this Q wave is greater than 1/3 of R wave, we take the distance that way, we calculate it, and if it is more than greater than 1/3, it is considered significant. Point number 2. If it is greater than 2 mm deep or greater than 2 mm wide, again it is known as significant. I mean, if somebody is having this wide QRS complex, wide Q wave like that, it is not that deep, but it is quite wide. Again, it is considered significant. Greater than 2 mm wide, and similarly, depth is more than 2 mm. And when I am speaking the word mm, that represent one small box. 1 mm vertically, one small box. 2 mm, two small box. 3 mm, three small box. Vertical boxes indicate voltage. And when we talk about the horizontal lines, 1 mm, one small box represent 0.04 second, and then 5 small box represent 0.2 second. I'll be telling you about those seconds and axes and all those things lately. So that's the story. Again, this Q wave should be seen in two adjacent lead. Like if a person is having Q wave formation, one in lead AVF and another one in lead V4, how important it is? It won't be that important. It won't be signifying major issue. But if it is there in 1 and AVL, now this is very important. It is representing upper lateral wall, old myocardial infarction, highly likely. Upper lateral wall, old myocardial infarction. Because what happened? We just discussed that there was a window formation. Initially, the wave was going upward. The wall got damaged, and now the wave is current is exactly in the opposite direction. So the two important things, the Q waves should be in adjacent leads, two adjacent leads, and they should be wall specific. And then the second is, this should be either greater than 1/3 of R wave, or it should be more than 2 mm deep or more than 2 mm wide. So this is all about Q waves, ST segment, T wave. As I told you, remember, Q waves can be normally there, T waves can be normally there, but in certain particular leads. Thank you very much.